Center for Spine and Orthopedics. I'd like to welcome everybody to our lecture on opioid dosing and the second lecture on opioid alternatives. Jacque Carbone will be presenting the first, and Dr. Paul Leo will be presenting the second half of these lectures. This is our third CME event in the monthly series featuring spine, orthopedics, and pain management topics. I also want to thank Health Images for co-sponsoring this lecture series, which it would certainly not be possible to do without them. First, tonight, Jacque Carbone is going to present part one on opioid dosing and alternatives. We will then follow that with Dr. Leo, who will present alternative ways to treat pain. A little introduction for Jacque. She's a lot of things. She's acute care, adult geriatric, and psychiatric mental health board certified nurse practitioner with 15 years of experience in pain management, which makes me feel bad about myself and my education. In September 2018, Jacque joined the Center for Spine and Orthopedics, and she loves working with medication, supplements, physical treatments to optimize patient outcomes and improve their quality of life. Jacque has 2 master's degrees from Georgetown University. I mean, this feels so ridiculous reading because it's so good. One is an acute care adult geriatric nurse practitioner. The other is a clinical nurse specialist. She recently completed her 3rd master's degree as a psychiatric mental health nurse practitioner at the University of Colorado Anschutz. I mean, she is one in our clinic who works best with addiction. I can say as a spine surgeon, I send a lot of my patients to her for evaluations pre-surgically, and a lot of my patients who have pain, who she works with them and evaluates them and frequently finds that their pain is actually almost a psychosomatic cause. Jacque is proud to be the co-author of the Colorado Altos and Cure programs. These are the programs of the Colorado Hospital Association's Opioid Reduction and Safety Initiative for the state. These programs entail limiting opioid use, using alternative to opioids for treating pain, and implementing harm reduction strategies and improving the treatment of patients with an opioid use disorder. Now, like she has spare time, but in her spare time, she enjoys working as I can't say the word, Jacque. In a Native American community, Curandera, did I say that correctly? All right, nailed it. I don't know what that means. And traveling, adventuring on her motorcycle, skiing, and spending time. Okay. And Jacque grew up in Lafayette, and she now lives on a farm. So before we start the official presentation, if everybody can double check, make sure that your microphones are on mute. We'll have a chat session open down at the bottom. Please feel free to put in chats. Our fellow Dr. Dornkamp, Dr. Leo, and Jacque will be moderating these discussions, reviewing. If you have any questions, please feel free to ask a question in there. We'll also have a section for questions coming up. So prior to Jacque's lecture, I'd like to welcome Dr. Kevin Downs, our SOM, with our beer and wine tasting. Dr. Downs is a retired OB-GYN physician who specialized in infertility. And also, to make me feel bad about myself, he, since he was good at that, he said, hey, I'll become a SOM. And and he's been doing that for 5 years. He is now an event planner and buyer at Whit's Wet Goods in Longmont. If you guys haven't been there, it's a wonderful store. He became interested in wine during his years as a physician, and I'd like to welcome everybody. Let's give a little round of internet silent applause for Dr. Downs.
Good evening.
You didn't do the thing.
Dr. Nash is here.
Can you hear me okay?
Oh.
Can you hear me okay? No, I'm not.
I can hear you just fine.
Okay, so we'll start out with the beers first. There are basically 4 beers were distributed. People got different beers, but I'll just introduce you to each of the 4 The beers come from the Saratoga Resort up in Wyoming, made by the Snowy Mountain Brewery. First one, Treasure Island IPA. IPAs are traditionally hop-forward beers. That means basically they have a bitterness to them. IPA stands for India Pale Ale because English brewers in the past used to use hops, which acted as a preservative. So when they sent the beers down to South Africa or wherever they had to send into the troops, they wanted to have their beer nice and fresh to keep them happy. This particular IPA is a West Coast style, which means they use hops that impart kind of a ripe fruit and citrus flavor to the beer. And it's a strong ale with an ABV of about 7.2. ABV is alcohol by volume. So about 7.2%. The next two beers are both wheat beers. The first one is an apricot wheat. It's an American style. American wheat beers tend to be very light and fresh. This one is unfiltered and pours a bit cloudy, which just expresses the flavor a little bit better. They put a bit of apricot flavor from a natural fruit puree into the beer during its fermentation. These are lower alcohol beers, so they're really fresh, particularly great beers for the summer. The ABV of this one is 4.8. The next one is a Saratoga Whit beer. This is a Belgian style wheat beer. These are slightly heavier beers. They use different yeast in the fermentation process, and they get a little earthier and funkier tone to them. They're wonderful beers. The malt in them tends to be a bit sweet. This particular beer, they add coriander and orange zest, so there's just a riot of flavor in there, and it's an excellent wheat beer. Finally is White Buffalo, which I find fascinating. This is actually a white stout. Most stouts are dark because they use very dark kilned malts that are just become very dark. Often they're called chocolate malts. And they actually impart a flavor of chocolate and coffee into the stout. I don't know how they do it, but somehow they get this exact flavor profile in a white beer. So those of you who got that really enjoy that one, although they're all great. So I'll turn to the wine now, which is my area of expertise. I thought I'd have a little fun tonight. So we're doing Petite. This is a fun wine that consists primarily of Petite Syrah with a little bit of Petite Bordeaux, hence the name Petite. I'm a huge fan of Petite Syrah. Petite Syrah, a lot of people don't know much about. This grape was created in about 1880 by a French botanist. His name was Francois Dorif. And he crossed two grapes. One's very well known to us, which is Syrah, and the other is a grape called Pelorsin. You've probably never heard of that, and there's about 25 acres of it in the entire world now, so it's essentially extinct. This particular grape was brought to America shortly after its right after its creation, and it quickly became very popular. It became extremely popular during Prohibition because the grapes are very small, very, very thick-skinned, and they transport really well. So all those people that wanted to make homemade wine during Prohibition just loved this particular grape because it would survive the trip totally across country. After Prohibition, when the whole wine industry opened up, Petite Syrah fell out of favor, and flavor both. And but since then, in the past 20 years, it's had an extensive recreation of interest in this grape. This grape is known particularly for its dark blue and dark fruit flavors. Hence, we're doing it with some chocolate-covered blueberries that work really, really well. This particular Petite Syrah is a fun wine. It's one of the Freak Show series from two brothers who are Michael and David Phillips, and their winery is down in Lodi, California. They're fifth generation grape growers, and decided to try their hand at making wines, and their wines are sought after and they're very popular throughout the country. This particular Petite Syrah is blended with a little bit of Petite Bordeaux for a particular reason. The one problem with Petite Syrah, tends to be very short. And what that means is the finish tends to be very short. So you get this huge burst of flavor and then it just gets cut off. But if you add another grape, particularly Petite Verdot, which is another French varietal, it just extends and expands that finish to make it long and lingering. And you'll find that with this wine. So basically that's it. I hope you enjoy the wine, and I hope you've enjoyed this little bit of a presentation tonight, and enjoy the rest of the conference.
All right, thank you. All right, Jackie, we are all yours for the beginning in our first lecture, Opioid Dosing and Alternatives.
Welcome, everybody. Thank you for joining me on a Wednesday night. I hope that you've got either your beer or wine or a beverage of choice in front of you. I want to give a quick thank you to Dr. Rumley and to CSO for making this possible. And of course, all of you for joining me tonight. I know that most of you are looking forward to getting your new CEUs met for the state of Colorado, and that's what we're going to cover. So sit back and enjoy, and write down any questions you have, and then afterwards, I hope to answer any of the questions that you have. We're going to get started. I'm going to go ahead and get my screen share up here, and we're going to get going. All right, so opiate dosing and alternatives. I don't have any disclosures for tonight. We do have 5 main objectives for this course. We're going to be able to identify some best practices for opiate prescribing, utilizing the most recent version of the division's guidelines for prescribing and dispensing opiates. We're going to be able to take a look at substance use disorders and understand the pathology and social issues involved with them. We're going to take a look at what's really needed for a good referral to treatment for substance use disorders. And we're going to be able to use the Colorado State PDMP, PDMP Aware, and understand how to act with other providers and all the extra information that you really can glean from this particular program and how it works for us. And then we're going to take a look at some alternative to opiates. I'm going to cover kind of the ones that we're going to mainly take PO, and then Dr. Leo is going to talk about what happens when we don't use a medication like that and where can we go for pain relief. Pain, right? I'm sure that none of you in practice have ever had anybody come in and say, well, you know, I've got this widespread throbbing, it's left and it's right, and it goes up here and way down there, and it's random, and right. I mean, they use tons of different things to describe pain. So we're going to do just a really quick primer and kind of what pain is and what pain isn't. And I'm going to try to spice this up a little bit with some mythbusters. So our first mythbuster is zero. So what does our zero mean? That zero pain is attainable. It's not even actually really desirable, and there really isn't a such thing as a painkiller. Zero pain isn't desirable because pain is an indicator to us, right, that something's wrong. So if people come in, and I get this all the time, right, you know, they're in a 4 out of 5 pain, and I say to them, well, where would you like to be? Oh, I'd like to be 0. I'd like it to stop. And I tell them, you know, that's just not realistic, because I want you to feel some pain. If you fall down the stairs and break your leg, I want you to know about it. If you get an infection with this incision, I want you to know about it. And my medication only works about 30%. And let's set you up for some realistic things. What's a pain that you can live with, and what is, you know, something that's going to absolutely impact your functionality. So we need to begin to talk about pain differently. We need to begin to talk about our medications differently, and something like a painkiller just isn't a true. So let's look at some facts. And these are interesting. I'm going to present them to you, and then I'm going to give you some ideas about why I think things have changed. So in 2011, about 11% of the United States had chronic pain and were given prescriptions, not onsons, but prescriptions for opiates were written. In 2012, 259 million prescriptions for opiates were written. In 2013, we decided we were having an opiate crisis, and the United States, you know, said, oh my God, it's a public health epidemic, right? And this is because a lot of this was leading to drug addictions, overdose deaths, and increased costs, of course, to society. In 2014, the number jumped to 19.2% of the population had chronic pain. And in 2019, the most current statistic that we have, about 20% of adults had chronic pain. Of these chronic people that had chronic pain, about 7% really kind of hit this chronic pain threshold that is kind of where we really start to take this really seriously. It actually limited their life activities for the past 3 months. If you look at between, let's say, 2019 and 2014, you have about 5 years there and it grew at about 1%, right? If you look at 2014 to 2011, we almost doubled. There's a few reasons for that. One was that a lot of our pain prescriptions and things like that weren't necessarily condensed into a certain area of chronic pain. Kind of everybody was writing these prescriptions for different types of pain. Another possibility, of course, is that we've become much better at defining what that is, and we've become much better at realizing that chronic pain is a disease. It's a disease process, and it's something that we can intervene in order to help with the quality of life. And of course, the most pessimistic view of this whole thing is once the opiate crisis hit, the only place that people could get these medications anymore was through having chronic pain. So more people were identified. Of those identified, chronic pain basically increases with age. So the majority of people that fall into the chronic pain category are over the age of 55. It was definitely the highest, though, among adults over 65 and older. And of course, all of these patients have some interesting comorbidities, obesity being one of the highest ones that there are. Other comorbidities, things like heart disease and chronic conditions, asthma, those kind of things, most of them are female. But just something to think about, just to kind of give you some facts. And let's give you a quick pain review. I know that all of you guys know this already, but I like to kind of get our space going here and where we're going. So acute pain is really a short-term pain. It comes on suddenly. It has a very specific cause. It's usually like an injury. And it lasts for fewer than 6 months and usually goes away once the underlying. So I fall off my bike, I break my leg. That's definitely an acute pain. Whereas chronic pain really lasts for longer than 6 months. And it's usually there even after the original injury is really considered healed. So that's an important thing. We have two other types, nociceptive pain. It's the most common type of pain, and it's caused by stimulation of the nociceptors, which are pain receptors basically in tissue injury. Of that, visceral and somatic are your two biggest ones. They often includes your skin, muscles, joints, connective tissues, bones. And it's often a little bit easier to kind of pinpoint the location of somatic, especially rather than visceral. Visceral tends to, I always think of visceral pain as a nurse. We had a lot of people that had pain after they had a laparoscopic surgery with the gas, because the gas caused pain down in their gut, especially if they had like a gallbladder, but the pain was in their shoulder. And you would get these calls, I had this surgery, my gallbladder's out, my shoulder's killing me, give me morphine. And I would say, roll on your right side and keep walking, because it's really about absorbing back in that, and the pain was really down there. So that's the way I kind of think of that one. Neuropathic pain. This is probably the pain that I deal with the most, and it results from damage or dysfunction to your nervous system. We deal with a lot of this, obviously, orthopedics and spine here at CSO. So this is probably the one that we see more often. And in chronic pain, probably lower back pain is probably the #1 pain treated. Now, I have another place called other pain. And I think it's really important to note, because it kind of makes a triad that I call the pain hell. And that type is the emotional, psychosocial pain. And I often get people who will come in, they've been great for a long time, and then suddenly I see a spike. Suddenly my medications aren't bringing them down to 5 anymore, and they're really sitting at a 9. And I say, okay, pathology hasn't really changed. You haven't really gotten worse. You haven't taken a fall. So, what else is going on for you? Tell me a little bit about your life. And what I find out is, somebody died, or they're going through a divorce, or they're worried about their kids, or they're in financial problems. And in fact, recently, in a current study in Psychological Times Today on pain, one of the largest reasons for an increase in pain during this pandemic was financial stress from the pandemic. So I thought that's your other one. But if you get all 3 of those going on, then you're truly in what we call the pain hell. And it's a tough one to treat because you're really stuck with what to do about this particular area. So what has changed and why? Well, in March 14th, 2019, the revised guidelines for prescribing and dispensing opiates were adopted by 6 of the Colorado's prescribing and dispensing boards. And this was in response to a bill that had been passed. The boards that had signed on for this were the Dental Board, the Medical Board, the State Board of Nursing, the Board of Optometry, the Podiatry Board, the State Board of Pharmacy, and I love the last one, the State Board of Veterinary Medicine. So all of those are prescribers in the state of Colorado, and they all had looked at these revised guidelines, and each of the guidelines is kind of broken out by your state board. So we're going to mainly look at the ones that are with the Nursing State Board and the Colorado Medical Board tonight. The revisions were necessary, like I said, because there was a new bill out. The Senate Bill 1822 was what had been passed immediately upon the governor's signature, May 21st of 2018. And basically what happens is that law had set forth prescribing requirements, such as the number of opiates that were allowed to be prescribed, and required for prescribers to take a look at the PDMP or the Prescription Drug Monitoring Program. And there were certain situations, and of course, as always, there's exceptions and there's allowances and there's different requirements for each place. So, but the state of Colorado decided that we all needed to be educated in this, and it was going to become a requirement for us to renew our license, which is why many of you are joining me tonight. So Mythbuster, number 1, what do you think we're number 1 in? We, the US, are number 1 in treating pain. No, that's not it. I wish that was it. We're pretty much number 1 in using opiates to treat pain. And that's pretty much what we do. We write a lot of prescription. In 2013, basically we peaked at 259 million prescriptions written, or basically 12 billion tabs of opiates per year. And we are better now. We're down to 190 million prescriptions. But really kind of, I guess what the Mythbuster should have said is kind of, we suck less. That probably would have been a true Mythbuster. So let's talk about the Senate Bill 1822, the Clinical Practice for Opioid Prescribing. Sounds very ominous, this bill. It basically introduces many new laws that prescribers must be aware of, and the bill outlines the guidelines for each one of the boards. And if you get into reading bills, because whatever reason you don't have enough time in your day, I guess, to go skiing or something, but you'd rather read bills, this is a good one to read. It's nice and long. There's different sections basically put out for each of the bill. And as typical, a lot of it is written in government speak, and it's a little confusing. So let's break it down tonight and let's see what you really need out of this. The biggest takeaway is under the new law, a prescriber must limit a patient's initial prescription of an opiate to a 7-day supply. If the prescriber has not written an opiate prescription for a patient in the last 12 months, and if they're a new patient to you, a 7-day supply. So if they're opiate naive, you're going to do a 7-day supply. If they're not new to you and they're not necessarily opiate naive, but you haven't personally written the script in the last 12 months, you're going to write a 7-day supply script. Now, as always, you've got to exercise your own discretion, okay, including a second one for a 7-day supply. This has been interpreted a little bit differently across the state of Colorado. You will get some pharmacies who, even though I may give my chronic pain patient who is not opiate naive, but new to my practice, 2 7-day supplies of their first time that I'm writing for them, I have had pharmacies say that they will not accept scripts written on the same day, that I need to have a reevaluation in between theirs. Thank God for telehealth, right? Most of us are using it now, and this is a great place to throw your telehealth in. Have them, or even have them give them a call. You can do a phone conference for this, but really think about that next 7-day supply, and we'll talk a little bit more about why. Exception. This is going to be kind of the way it is with most of our stuff that comes from the government, right? So these limits do not apply if, in the judgment of the prescriber, the patient has any of these things going on. They have chronic pain that typically lasts longer than 90 days. And I will tell you that they still make me do a 7-day supply, but that's what this law says. If they have something that's going to basically take them past the time of normal healing. So maybe your patient had a biopsy and it got infected, and the normal healing time was going to be, 14 days, but now with the infection and antibiotics and the edema and everything else that's going on, they're going to take 30 days or 60 days. And it's determined by the prescriber, of course, that they need to continue that, or following a transfer to another prescriber. I personally like to wait and not prescribe directly upon getting a new patient. I like to talk to the prescriber that I'm getting the transfer from, so I always have them wait. I think that's just kind of a little pearl that keeps us safe if you see that. If they've been diagnosed with cancer and they have cancer-related pain, or they are post-surgical, and that because of the nature of the procedure, it's expected to last more than 14 days. This is a nice exception. It's not necessarily the safest way to prescribe, and we'll talk about why in a little while. Or they're undergoing palliative care, of course, hospice, and you're basically helping them with pain and stress resulting from a serious illness. Now, these exemptions are allowed for physicians, physician's assistants, and advanced practice registered nurses only. So those are the only boards that do this. So I guess that means if FIDO is going to be longer, that can't do that, but that's what they say on here. So the next takeaway that you need to know is after the first prescription, the prescriber is required to check the PDMP if you're going to prescribe additional opiates. I would tell you as a chronic pain interventionist provider that I would check my PDMP if I was going to hand out any type of C2s, benzodiazepines, opiates, Lyrica, gabapentin, testosterone, anything that appears on your PDMP, I would check before writing my first script. There's nothing worse, and I learned this as a new prescriber, than handing out my first 7-day script and thinking it was great and realizing that they had just filled 180 from their dentist. So double check these, okay? But I think that this is an okay law. I think you should definitely check it at least at this time. I would urge you to check it before ever writing a narcotic script. Failure to check the PDMP constitutes unprofessional conduct of the prescriber. And if you repeatedly do this for the new requirement, it can deem board action. Now, this is an interesting one because it says it right there in the law. And then I'll tell you what they say a little bit later, which kind of negates it. So the exceptions again, the second field requirement to check the PDMP, it doesn't apply if they're receiving it in a hospital, a skilled nursing facility, residential or correctional facility. If you have cancer, if you're undergoing palliative or hospice care, if you're having that surgical pain that because of the nature of the procedure is expected to last more than 14 days. Here again, my suggestion, my pearl of advice would be that you check the PDMP before you ever write that post-op script. There are people who are getting post-operative scripts and going through a lot of surgery just to get these scripts. And so recently I had a patient that had carpal tunnel, and I had agreed to cover their carpal tunnel because I also cover their chronic pain script. And when I got into the PDMP, turns out they had seen 3 other surgeons within about a 4-week period and had gotten quite a bit more. And so when I went back in, I said, well, I'm not going to write a script because you have from your oral surgeon, and you also have another one from this orthopedic. It looks like maybe they did some sort of excision on a cyst, and so always check it. I just think that that's really important to go ahead and do. And of course, if you're receiving treatment during a natural disaster or during an incident where there's mass casualties taking place, or like a single dose. So maybe you're doing that biopsy and you'd really like to give them a little tramadol or Norco or something like that after, and you're doing a 1 dose kind of thing to take that evening or something like that, then you don't need to double check. During the pandemic, they have released this exception. This is considered one of those times when we don't need to be checking. I would still check. It's not that hard. Many of us have it in our EMRs now, but we'll go further into what it can tell you. I double check a lot because it gives you so much information, such a great tool. So our next takeaway is after the second opiate prescription, the law has no further restrictions on healthcare providers' prescribing practices. The new law does require a healthcare provider to sign up for the PDMP. You can have 3 designees and your own provider, and you have to specify the provider's specialty upon the initial inquiry. So the first time that you use the PDMP, it's going to ask you what it is. This gets a little confusing. The first time that I registered for the PDMP, I registered under PM&R. And when they sent me my quarterly, I was like the 3rd highest prescriber in PM&R. And I was like, oh my God, I mean, I can't be that high. I have people under 200 and I'm doing all this great stuff. Well, they had a different section for interventional pain. And so then when I did it there, I came down to kind of a medium area. So just kind of know that it's not a fine science yet, okay? And they kind of compare you to an area. You get a quarterly update that you can access. It kind of tells you how many you wrote, what kind of milliequivalents, what your average milliequivalencies are. It also tells you how many scripts that you write to people that are taking benzodiazepines, and how many scripts you have with people that are on Soma. And I would say, those 2 areas are definitely areas that you really want to decrease. We'll talk a little bit about prescribing with a benzodiazepine and what are some of the best practices with that a little bit later. But I think it's a great program, the PDMP, but there's a lot of things that could be improved yet. Also, it states that a violation of the new requirement doesn't constitute negligence or contributory negligence per se, and does not create a way for doing any private action or serve as a basis or a cause of action. But if you remember earlier, it did tell you the board could take action against you if you keep failing to look at that PDMP. Government speak again. I did talk to a lawyer about this just to kind of see what they were going on. And I also called the state of Colorado. So the boards are more interested in non-punitive corrective action for this and education. That's what they say will happen. And then of course they put it this way so that basically you can't just have a lawsuit over not checking the PDMP, basically. But what the law really intends. So these are guidelines that do not have the force of law. We'll talk about that. But they're intended basically to assist the practitioner in order to make some good decisions. And they're hoping that with these guidelines that you'll collaborate with mental and behavioral health, and that you'll have a bigger pause basically to really consider some alternative to those opiates. And that you really, and already are, because I have great providers listening in tonight, I know many of you, that you're going to develop a treatment plan that's really a partnership, and you're going to look at functional goals, and you're going to make an exit strategy. I would suggest anytime that you give an opiate alternative, or treat pain, that the 2 most important things in here is that you are documenting function and exit. Function, exit. They're great things to have. The other thing is that they intend for us to do a lot of education. Of course, we already do this, right? Risks and benefits, why we're doing all of this. They want you to have some, what is kind of crucial prior to initiating therapy. And then before increasing dosage and things like that, they start talking about the bright line. We'll talk about the bright line in safe prescribing thresholds. The bright line is really supposed to be like a shining example of when we stop and do some more thinking. But we're all excellent providers, so I'm sure you guys do this already. And then, they want the reduction in days of treatment for acute pain. So they really want us to think about, hey, I was out walking my dog, I stepped off the curb wrong, and I twisted my knee. And, maybe you give 7 days of, 3 times a day, some Percocet for that. And they want you to really think about the fact that they probably don't need it for that long. Maybe they really just need 2 days, or they really just don't need it at all. And there's some other things we can do. The assessments of the patient's functionality early and often. The easiest way to document this, I think, in your note is I ask him about what activities has this injury and this pain caused them to stop doing in the last 3 months. So, you know, if somebody comes in and they have a twisted knee and they say to you, well, I can't walk my dog and I'm having trouble getting in and out of the shower. And, you know, I'm having a heck of a time even making my dinner right now because I can't stand at the stove that long. I put all of that right in my note right there. There's your functionality. Okay. This doesn't have to be fancy or anything like that, but you definitely want to get that functionality nailed right away. And then showing that frequently you're rebalancing the risk and benefits of continuing opiate therapy. And what they're really looking for in this, what this means is rebalancing this all is, you know, if you're going to continue something, you say something like, you know, the benefits outweigh the risks currently for patients' functionality, well-being, and quality of life as the patient is able to go back to work or the patient is able to take care of themselves independently. Or, you know, despite the new diagnosis of COPD, we are going to continue the patient's PRN 30 Percocet every 3 months, as I feel that further hindrance around their seasonal arthritis with the cold weather in Colorado would further compromise their ability to do rehab, or would further compromise their ability to participate in activities that you know, help to strengthen the patient. So you just want to make sure that those kind of things are in there. What else does the law intend? Well, it's the incorporation of the 3 bright line safe prescribing thresholds. And this is the part where the prescriber really should kind of reevaluate the patient for the effectiveness of the opiate treatment. We're looking at risk mitigation. We're looking at things like naloxone, and we're looking at, you know, should opiate treatment continue? Now, the federal government has set this at 120 morphine mill equivalents, where the CDC has set it at 90. The state of Colorado is extremely conservative and they have set this at 50. Now, if you have never figured out what MMEs are and you don't know how to do that, we're going to talk about that a little bit later. 50 is really low. I'd be just really honest with you. And it's fairly easy to go over fairly quickly, especially with something like a Percocet script. So we're going to take a look at that. And then, of course, you know, I'm thinking I've had this patient for a while. The intermediate stuff isn't really working very well, the immediate release things. So I'm thinking about adding an extended relief formulation, an extended relief tramadol, you know, morphine, OxyContin, those kind of things. This is another bright line where you want to go, is this really what we want to do? There's some really big benefits to adding extended relief. And there's also some downfalls of this type of thinking. So we have to take a look at that. And then what duration am I really getting myself into now? You know, I started out giving a 3-day script, and now I've issued another 3-day script. And this was really supposed to be an acute, non-traumatic, non-surgical pain. And now I'm into 14 days, or I'm into, this patient keeps coming back, you know, every month wanting 10 more of this. So now I'm really into the subacute types of things. And some of our surgeries even go into this kind of subacute area, even this acute type of thing, because they take longer to, you know, you expect them to only need 7 days. And there's a complication of some sort. You know, the patient decided to slip down the stairs and retore their shoulder, some of those types of things. Or they really have gone into kind of a 90-day deal where the pain is just not changing, the functionality is not changing, and they're in your office constantly telling you that there's more and more pain, and it's not cancer. So when you take a look at that, it's really bright line is dosage, formulation, and duration. Dosage, formulation, duration. That's really where we're going. Oh, it's time for a Mythbuster. All right, 100%. Let's see what this one's about. 100% of surgical procedures, especially major ones, require opiates for pain relief. This myth isn't true. They don't require opiates for pain relief. And in fact, they're doing knee replacement and hip replacements now, cervical surgeries, things like that, that we used to give quite a few weeks of opiate therapy for, and they're doing them without them. From a personal experience, I recently had a family member over at Anschutz at the university go through 4 surgeries in 4 weeks, and they gave him 2 Norco for all of those surgeries, and he has drains in for 6 weeks. And you know what? Through education, through some use of some other modalities and things like that, one time have I given him that Norco. So it really can be done, but they've done some amazing blocks with him. And these blocks last for a long time. And that's great. Use things of like the QVAR balls, really having a good anesthesiologist when you're doing these surgeries that can really put in a good block, and having physicians and surgeons that really understand blocks are just a huge, huge part of no longer needing to give opiates, even for major, major surgeries. So Durango, up in Durango, the hospital up there, Mercy Medical is run by Centura facility. We had the most amazing spine team up there, the most amazing anesthesiologist I've ever worked with. And I was a recovery nurse up there. I worked up there for 6 months on a travel contract. I gave 1 ampule of fentanyl for 6 months. But they use blocks, and before major surgeries, patients were required to take biofeedback classes. So it can be done. I think it's becoming more of the norm. I'm hoping that these practices are going to become much more commonplace but we really have to re-educate the public. That's the biggest thing. And as a pain professional, I can tell you that I wasn't all that thrilled about my own family member not given any. I had my doubts, but I've been really, really impressed with the way that they did this, even with major surgery. So I think that that's a good way to go. So what else does the law intend about this bright line of safe prescribing thresholds? And basically, you know, they're talking about the effectiveness and the opiate treatment and risk mitigation. The evidence-based guidance for all of Colorado prescribers and dispensers. And now we're talking about the guidelines. So we just did the law. That was the bill that came out. Now we're going to talk about these guidelines. And these are the guidelines that were accepted by the different boards. And it's for patients over 18 years of age. So if you treat anybody in the under 18 pediatric type of thing, this doesn't apply. And they are suffering from acute, subacute, or chronic but non-cancer pain. Chronic pain and chronic non-cancer pain refers to pain that lasts longer than 90 days or is beyond the time of normal tissue healing, and is non-terminal. And it doesn't include conditions, and here's where you have a bigger exception, like cancer, but also scleroderma, multiple sclerosis, muscular dystrophy, rheumatoid arthritis, or other conditions that might require palliative or end-of-life care. And I think that's really important to take a look at if they're requiring palliative or end-of-life care, but don't necessarily fall into this. And you have to kind of decide if you're practicing in a palliative type of atmosphere for that patient or not. So prior to dispensing or doing guidelines, right? This is what our guidelines tell us. You want to develop and maintain competence. Well, that's why you're here tonight, right? You're all about maintaining competence. And of course, you've always had great competence before you came to this class. So the next thing we want to do, and we do this all the time again, is diagnose and evaluate our patients. We're all really good at this part. Consider alternatives to opiates. This is a little bit harder. Why we typically tend to consider alternatives to opiates, our patients aren't quite as good as considering the alternatives. And there's nothing like explaining to a patient who has a pain in his foot that you're going to give him a med that when he goes home to Dr. Google is going to tell him that he has depression. So this is going to take a lot more education on our behalf, especially when we're considering these alternatives. Collaborate with the healthcare team, right? Because we've got so much time to do this particular part of it. But there are some times when I really think that a quick phone call or a note, or even just making sure your note gets sent to the next person is a really good idea. They are big on more collaboration with the healthcare team. And I think that this is important, but this is a hard thing to do. And I realize that we're all behind the gun a lot of times in the amount of patients that we end up seeing. Patient education. Patient education. This is a prime thing to focus on. And developing that exit strategy. This also is a tough one because a lot of people don't really think about how they wean themselves off even a 7-day script. We're going to talk about this further. So what are the big 3 things? Dosage, formulation, duration. This is really the key to everything there. So Colorado prescribing guidelines, dosage. above 50 MMEs, ensure the patient condition outweighs it. Make sure you look at risk and benefits and ensure that risk mitigation is in place. Risk mitigation are things like having an agreement, making sure that they're locking up their medications in a safe and only taking out one day, being really clear that you are not replacing these if they're lost, stolen, taken out of their place, a pet eats them, they get rained on. I've heard it all. These are the only ones that ever go down the sink, right? Formulation, extended relief, that long-acting stuff. Make sure it warrants it. Make sure that it outweighs the risks here. Consider concurrent medications that potentiate the side effects. Anything in the psych class, so any of your mental health stuff, but also a lot of the medications that we give people for COPD and other common things, even hypertensive medications like metoprolol can potentiate this. Nausea medications like Phenergan, cough medications. These are a big one people like to take together. And then risk mitigation strategy. I really highly encourage you to do quantitative analysis with your analysis on this. It's amazing what you find out that people are taking together and shouldn't be. And then of course, duration, right? Typically 3 to 7 days. But when you're looking at those longer scripts, you've got that little old lady who every 3 months really kind of needs the 10 because she's got bad arthritis. Just make sure that you're really documenting that, that the risks of keeping her mobile and things like this really outweigh this. Obviously, you want to show clinical improvement. Are these things allowing them to do quality of life things? Are they making sure that they are getting through everything that they need to get through? ADLs. I had a patient that was on high dose, even for a chronic pain prescriber, a little over 200 MMEs. I brought her down to the 50 MMEs and I was ready to place her into a nursing home. She absolutely couldn't care for herself anymore. I decided to go back up. Her golden place is at 210. At 210, she has quality of life. She takes care of herself. We're not looking at nursing home placement. But I've got a lot of documentation showing that I did really try and that this is what happened. And both myself and the primary care physician agreed that we would go for nursing home placement on this patient if a rise in this didn't work. So these are really important things. Mitigation strategies. Again, I like to have an agreement. I make sure I do UAs, pill counts. Pill counts are wonderful things. Let them know that they can come in for a pill count at any time and you will call them in for this. And then of course, a prescription for naloxone. If I give that second script, a lot of people feel that you're telling them they're going to be addicts or they're going to misuse. And what I remind them of is that something as simple as not drinking enough that day increases the amount of my opiate. So you could be a perfect patient and take it exactly as I prescribe, because we know that we always have compliance with our patients. And you can get into trouble because your kidneys aren't working that day or you are dehydrated that day. Something else happens. And so I tell them they should have it for that. If they have pets around, I like to make sure that they have this because all they have to do is drop a pill and they've overdosed their pet, and you can do a naloxone to a pet and save their lives. Or, they have those kids around or the teenagers. This is a thing for them. And you want to make sure. I would hate to have a grandchildren that picked up a pill thinking it was that I dropped accidentally, that thinking it was a piece of candy or something. So I just tell them that, this is why I don't think that they're ever going to need it for themselves. I hope that they never do, but I'm going to make sure that they have it just in case. These are really important. So what are the tools and what is a trial? What does that mean for risk mitigation strategy? Well, the tools are things like your screens, using things like the SOAP, the oswestry, functional RX screens, these type of things to make sure that you aren't giving them to a patient who has a really high potential to become addicted. It only takes once to get an addiction. And also making sure that they're using them correctly, that what they're telling you about their pain, because pain is subjective. I'm sitting here right now and giving this speech. It's putting me in a 9 to 10 out of pain. No, I'm kidding. But does that show on something that is able to kind of quantify pain in a much more clinical way, like oswestry, which is used for the lower back? So does that work? Referral to a pain management specialist. And I will give you my personal cell phone number. You don't have to refer to me. It's okay. But if you're managing these in your office and you're a little confused, you're feeling a little uncomfortable, you're wondering about some of the other things that you could possibly do and how to talk to them, please give me a call. I'm always happy to collaborate with my fellow colleagues on what they're doing, because your management of pain and my management of pain, it makes society a better place. So let's do this together. Concurrent naloxone prescribing, we talked about that. And of course, patient education. This is a big one, and this is so important. Really educating your patient. about when to take a pill. Just because you give it to them 3 times a day doesn't mean they should take it 3 times a day. They really should evaluate what their pain is and decide, am I going to go out and go garden, or am I going to sit here and watch Days of Our Lives? Okay, so you got to do that. And then you got to talk about when you're going to discontinue opiate therapy. I tell my patients straight up, if you risk my DEA, we're discontinuing. If I feel like this is no longer contributing to your quality of life and you're just going to sit on a couch somewhere, or you're not going to be functional, you're not going to try to do some physical activities, we're discontinuing. It really should end. Hey, the first 3 days you're right after the surgery, they are going to probably be difficult. I want you to take this when you're in a 7 out of 10 pain, not before that. But after that, things should get easier. And the most important thing you can do, so you no longer have to need this, is move, get to moving. And then what is treatment for opiate use disorder? There are patients that you give it to the first time, no matter your best intentions, you've done all your screens, everything else. And it turns out that they have an addiction that you've turned on. So what are we going to do about that? So some helpful tools. I love my opiate calculator. And you guys are going to laugh at where this comes from. This comes from the Faculty of Pain Management, the Australian New Zealand College of Anesthetists. I think this sits on Android, on iPhone, really, really easily. It gives you different morphine equivalents. If I'm giving somebody, let's say I'm giving them 10 Norcos a day, and I'm having them take 4 a day, I put in the fact that I put 40 in there. It gives me my morphine equivalents, but my patient comes to me and says, oh my God, the Norco is making me sick. And I'm thinking, I'm even good trained to do tramadol, but how much tramadol should I give them that's equal to this? I hit the little calculator piece and it tells me. So it's great about that. And it can also change things. Like a lot of times we get patients, right, that are coming out of some sort of acute care. Maybe they've just been in the ICU and we need to keep them on pain meds for a little while longer, but they've been getting IV Dilaudid. How do I transfer that to, you know, some Percocet or something like that? This calculator will do that. Or they've been wearing a fentanyl patch and come into my office and I don't want to prescribe a fentanyl patch anymore. How do I change that over to maybe some Dilaudid or maybe some Norco or something like that? This thing will help you do it. I always take equivalent morphine equivalents. So what was equivalent in Norco, I change over to Percocet, and then I drop it by 1 pill. Best way to go, because the body's going to do it a little bit easier. I love this. If you're a new prescriber, or if you feel really uncomfortable kind of getting into this whole pain, the proper prescribing of controlled prescriptions drugs, this comes out of Vanderbilt University. It's a wonderful pocket card. It's free on the internet. You can take it, print it off, and scrunch it up. It gives you your key points, what you have to cover during a clinic visit. SBIRT, right? Your lovely SBIRT. This is your screening, your brief intervention, and your referral to treatment. What kind of things you should document? The 4 A's. You should always ask, is it giving analgesia? What activities are you still being able to do? Have you had any adverse events? Are you having constipation? Those kind of things. And then anything else? Are you feeling like you're craving this? You know, you don't have to necessarily act if they feel addicted, although a lot of people will answer this question when I ask them if they think they have an addiction with yes. And we go through what is an addiction. And for a lot of my patients, it's because they're dependent and tolerant. And that is not part of addiction. It's an important part to know. You'd have to change the resources. The resources for out there in Vanderbilt and Tennessee and stuff like that. But I just changed those out. But it's a great little pocket card, really helpful when you first start off. And a good UA is as good as gold. Let me tell you. You want to be able to see what they're taking and why. Is it methamphetamine or is it Adderall? Are they not telling you that they have been taking their wife's Valium, or, you know, that a lot of people that are drug seekers that are really good at this, they know that Suboxone will keep them from going into withdrawal. You want to know what that looks like and for how many days all of this stuff is in there. I can't tell you how many people know in Colorado. I had an older gentleman. He could not afford his Percocet script. He didn't want to tell me about it. His next door neighbor said, hey, I get Percocet all the time and I can get it to you a lot cheaper than what you can buy. All you have to do is give me your script and I'll give you enough Percocet. Well, it turned out to be carfentanil. And I picked it up because I picked up that the fact that he had the fentanyl metabolite in there, and we had a really big talk. His wife thought he'd started drinking and she was ready to divorce him. So we had a really good talk about this. So dangerous type of things like that, they should do all of this. You should be able to tell if a person, if you've got them on long acting, they should have the metabolite. If they're taking these the way they should and not just the day of your visit, they should have the metabolites. So get to know this. A UA, like I said, it's as good as gold. Ooh, a myth buster, 0.0 or 0.1%. What do you think that's at? Oh, addiction. We were all taught addiction is extremely rare, or at least us, well, if you're as old as I am, you were. 0.1% to 1% maximum. No, about 6% of people who are on opioid prior to surgery and are giving them post-surgically are still taking them a year later. 3% are still taking them 3 years later. And this percent goes up to 20%, or 1 in 5, or if patients are given 14 days worth of meds with their first prescription, hence the 7 days. And since the opioid crisis, the number has doubled in people that have chronic pain and addiction. So it's really important to know what addiction looks like. Objective 2, participants are able to recognize it. Let's just bust into the substance abuse, right? Diabetes, hypothyroidism, asthma, substance abuse disorder. One of these things is not like the other. No, actually, these are all the same. Yeah, I know. I really did go to Georgetown. They are really the same. All of these disorders are chronic. They're subject to relapse. They're influenced by genetic, developmental, behavioral, societal factors. And all of these disorders, with the affected individual, they may not comply to our treatment plans. I know it shocks you not to have somebody comply with a treatment plan, but it's true. So let's talk about substance abuse disorder. If you don't know what SAMHSA is yet, Google it now. SAMHSA is the best resource. If you're having trouble getting your mind wrapped around this, you're not sure if somebody has a substance abuse disorder, especially some of the unusual ones, things like screen disorders, gaming, smoking, well, we all kind of know about smoking, caffeine. SAMHSA pretty much covers it all. So Google it. They have lots of free CEUs. They do a great job of this. But they say that basically it's a recurrent use of drugs or alcohol that causes clinically significant impairment, health problems, disability, and failure to be able to meet your responsibilities. The DSM-5 actually has criteria for this, and this is what you would want to document in your note if that's the case. So basically, notice that none of this says dependence or tolerance. They have cravings. They are wanting to cut down, but they can't. Oh, I really wanted to cut down this month, but the cold weather came in. Oh, I really was going to cut down this month, but my mother and I had a fight and I went ahead and used again. They're taking the substance in larger amounts for longer periods of time than they're meant to. So you give a script for 30 of them. They're supposed to take them once a day. They come back in and they tell you that they ran out 2 weeks ago. Okay. These are all red flags. Now you need to have 3 out of the 6 of these to actually diagnose a substance abuse disorder. They're neglecting other parts of their life. They are having trouble with their spouse. My spouse hates that I take these. We have fights all the time about it. Red flag, need to look at it further. And then using it when it puts you into danger. So, they're driving on it. They're going to head out to the bar and they're still drinking. I recently had a patient who's on a long-acting med. And just luckily, I happened to get a phone call that he also was in a motor vehicle accident on his motorcycle and his blood alcohol was 286. He's been on these meds. I inherited him. He's been on the meds for about 15 years. And so when we had our little talk, I was like, I think you got a problem. And here's why, because, you're using 2 substances that you know better to use. You've been at this long enough and you're high. This wasn't a beer. This wasn't a sip. This was a lot of alcohol. So this is a way to begin that and to know about that. Let's talk about the pathophysiology of addiction. I'm sure it's review for a lot of you guys, but I think it's important to remember that it really is about the basal ganglia, the prefrontal cortex, and the extended amygdala. The basal ganglia is really our reward pleasure center, right? So a lot of things when we first get our substance and begin using it, this is where we get a lot of that when you first hear about the high and stuff like that. This changes, especially if you have addiction later on, but this is definitely where that pleasure center starts. And then the extended amygdala is involved, of course, in stress and feelings of unease, anxiety, irritability. And often this is the part that people want to skip and withdraw, right? But it's a driving force. If they've ever been through this, it's a driving force to keep using. And then your prefrontal cortex, this is the one that makes all the decisions, right? Well, it's also the one that starts the compulsion and impulsivity and then turns into the reasoning behind it. I think a really important part to remember about this is that they really are these 3 areas that are involved. So let's talk a little bit about the basal ganglia. The nucleus accumbens is the first area that is involved in this. And this is kind of up towards the prefrontal cortex, if you look at my slide. And it's motivation and it's experience of a reward. And so this is kind of what motivates us to keep using. And then of course the dorsal striatum, which is involved in forming habits and other routine behaviors. This is what kind of sets up the constant use, right? We get into a routine of all of this. The extended amygdala, this is where you're really looking at kind of the subregions. It's located beneath the basal ganglia, and it's kind of the reactions to stress, but it's also your flight or fight, right? So this is kind of one of those types of areas that kind of spurs on our use through negative reinforcement of the whole picture. And then the prefrontal cortex, which is really about developing that executive function, this ability to organize thoughts. It's also what gives us our rationalization for use. So rationalization for use, I had a patient come in and I said, oh, there's cocaine in your UA. Can we talk about that? And she said to me, well, you know, I'm on Adderall for my ADHD. And I said, yes, I know that, but you're telling me it's well managed. And she says, well, it's only really well managed when I crash up my Adderall and snort that up my nose. That's what really helps. But you know, that burns. So I have to follow it with some cocaine. Well, that's a heck of a rationalization. It doesn't sound too rash to those of us that don't use cocaine, but to somebody who is an addict, it sounded like a great rationalization that she let me in on right there in the office. And it's a cycle. You're binging, your intoxication, that's your basal ganglia, withdrawal, negative effect, that's your extended amygdala. And then of course your preoccupation, your anticipation, you can't wait to get it, the rationalization behind it, that's all prefrontal cortex. So that's really where all of this is working at. And then of course you combine this with some behaviors. The 4 behaviors that are central to this addiction cycle: impulsivity, positive reinforcement, negative reinforcement, and compulsivity. And impulsivity turns into, when you get into your addiction, compulsive behavior around it. I have a lot of people that come in and they say, oh, you know, I prefer my heroin at 6 o'clock in the morning and then I use it again at 10. And then I really like it again before I have to go in and talk to the boss. And then typically at home to unwind, which happens around 7 or 8. I mean, it's like they're talking to me about how they take a Q80 scheduled medication. So it's definitely there. Really what all of these substances do is they hijack our brain, and you can take a look at the scan. I think it's great. So no drug use. Look at all the beautiful activity in our brain, right? Now, this is somebody with a cocaine addiction, 10 days without cocaine. If I were to screen them, I would get a clean screen here. But the brain has not recovered. 100 days, the brain is not recovered. There's absolutely nothing in our toolbox that can do what this does to the brain. And that's the biggest problem with addiction. We really cannot replace something one-to-one. So you have to recognize it. Use your expert, CAGE for alcohol abuse, SOAP for opiates, ASSIST for alcohol. I'm going to do a little plug here. I love DXIQ, and they have all of these different screens on it. When I want a screen done, it's sent to the patient's phone. They take the screen, they score the screen for me, send it back to me so I can put it into my note and I can talk to the patient about it. And, you know, let's face it, it's worth about $30 to $45 extra if I do this during a visit. So really worth it, but more importantly, really worth it for my patient. And I don't have to take the time trying to find these things. There's a couple other companies that do that. I don't know who else they are, but DXIQ is one of them. So this is a resource for you. How you approach this is everything. These patients have already entered their own prison and they've already tried breaking out of this wall. What our job as providers is to look for the fence and the gate. They're there in the wall, but that's our job. We have to get in. So that's what we're doing. We're looking for the gate and the fence. There's a lot of social effects to addictions, personal, family, community, nationally, globally. I thought that was kind of an interesting little pictogram. It's got alcohol involvement. Some of it we figured out, right? Obviously road traffic accidents, but mouth and oral pharynx cancer, poisoning, falls, hypertensive, heart disease, breast cancer, other cancers. I was really surprised at the involvement in this kind of stuff. So huge outreaching reasons. And this is just alcohol. This is legal, right? So 33% is greater than 55%. 33% is greater than 55. I don't know. Maybe my math is off. Let's see what this one has to say. Oh, opiates are the best. Not true. 33% pain reduction. 30% is what I usually tell my patients. That's the best I'm going to do. So if you're a 10, I'm going to get you down to a 7. That's the best I'm going to do with meds. But it has been proven in several studies that 55% pain reduction with a Q3 rotation of ibuprofen at 400 and Tylenol at 1,000. So there are better ways to do this. And I realize opiates are your alternative because how many of your patients tell you, I've got GERD, I've had ulcers. If they haven't though, and they can take this, this is really, and that's why we also have got to educate people not to take ibuprofen for sleep and things like that. They really are a good source for us. So objective number 3, we're going to understand what aspects are needed for a good referral and how basically to get into the resources in Colorado. So you have a positive screen. I have an addiction. Well, this is what a dog would do. 911, what's your emergency? Well, my balls under the couch. Have you tried barking at it? Oh, that didn't work. Oh my God, what do I do? Right? We all kind of have the one go-to for this. I like his little meme. It was fun. I'm going to try and give you a few other ideas besides just barking at it, okay? And that's basically motivational interviewing. Free CEUs on NAMNE for motivational interviewing. You'll find it out there. This is a great deal. I might like it because they use a lot of little acronyms like ORAs and darn cat. I love saying that I darn catted somebody towards change. But there's the process for it. We should be using it no matter what you're doing. This is a great way to get people to be more compliant and things like that. Establishing a partnership, being clarifying what our visit's about, talking about the reasons for change, and then coming up with a way to do that with open-ended questions and affirmations. This is preached as all the time, but it really motivational interviewing is an art. This is by the American Society of Addiction Medicine. It kind of helps you figure out what kind you need: intensive outpatient, partial hospitalization, residential. I'll be honest with you, in the state of Colorado, these are really hard to find. So these are gems, but if you're going to have some success, I always like to write in there that despite insurance coverage for this patient, I really am recommending this, but I'm having to go with a lower version of coverage due to lack of resources or blah, 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 blah. But this is a good one to help you through. And then 211colorado.org. It does help you find what's around in your area. The veterans, if they have any sort of history back there, plug them into the veterans. They're really good. If you can't do anything else and there's no way that you're going to get them into anything, well, online now is your AAs, your NAs, your SAs through Facebook. So it really is taking off on social media. They have chats that are just writing in. They have things that are live. They have telephone for people that don't do the computer. And of course, in-person meetings. Rational recovery. If it's incident related, like I had a sudden death and I really started drinking hard, you might be able to do rational recovery, which is the ability to go back to substance use in a modified and responsible way. And then of course, Google, right? Google can find anything, so Google it. And that will be really, really helpful. I would give you a list of like who's doing this right now, but the truth of the matter is it changes probably every 3 months with places opening and closing. So, and establish some of your things. These are great places to do some marketing at, right? Go in, find out who the providers are and what they need. 1 + 1. 1 and 1 are equal, right? They are the same. No, they really aren't. Treating somebody with medicated assisted treatment. So here we're probably talking Suboxone and the injectable Sublocade. Also Vivitrol or things like that. You're just substituting one addiction for the other. You're not. Again, depends versus addiction. The latter, craving, compulsive use, and continued use despite the consequences. The other one is like giving insulin to a diabetic. We're treating the underlying cause and we're giving them a fighting chance to actually live through this disease. Let's talk a little bit about the PDMP. I love the PDMP, and let's understand kind of how to interact with it and what you can gain from it. So basically what it is the pharmacies upload the prescription data each day. They're supposed to each business day. Users like ourselves, we access this, we review it, and then we can make more informed decisions about our prescribing, especially of controlled substances. Now, who else can obtain information from this? Notice that a lot of this has to be with a court order or subpoena, but your regulatory boards, your law enforcement, of course, other practitioners, including those outside of Colorado. I prescribe to a lot of people in Wyoming. Wyoming is not part of the Colorado base. Colorado base covers, I believe, 15 states. I could be wrong on that. Don't quote me on that one, but they cover a lot of states. Each state sets up their own requirements for these programs. Wyoming opted to do its own, but I can sign up because I can prove, even though I don't have a Wyoming license, I can prove that I treat people in Wyoming and I want to see what their fill ratios are. This is becoming kind of a moot point because like state of Texas, you have to have a Texas license and Texas approved script paper to even get one in there. So again, it's crossing things like that, but you can have their patient can receive their own copy. And of course, the coroner and medical examiners under specified circumstances. Let's take a look at what this thing looks like. So the biggest thing is it gives you kind of the total prescribers. This person has 15 different prescribers and 4 different pharmacies. On an average, there are about 132 MMEs, which is a little bit higher than the federal average, but a little bit low for chronic pain. And they didn't have any bupinephrine. It also tells me that they're getting 120 oxycodone. And the big thing is, so I wrote this prescription on 325 and they filled it on 326. I can look back at that prescription and I can go to the next time that they had the 120 and oh, look at that. They filled it on February 28. So this person filled early and I'm going to want to know why, because you have to add days from the 28th because February has 28 days. So why did they get a script early? These are the kind of things that you can tell. I can also tell what my daily dosing of MMEs are, my 90, my 60. How are they paying for it? Well, these particular people are on Medicare or commercial insurance. I want to know if they're paying cash. It is Medicaid fraud if they pay cash on Medicaid, and you will have a problem. So I want to definitely check into this. I can also see, though, that this person mainly fills at Walmart, and they're mainly filled by myself. So except for this level 4 hydromorphine, and I can tell exactly who did this. This gives me everybody who's been providing for that. And look at that, they filled with, and a lot of these people I know, they were fine. I realize that part of the 15 is a bunch of people from my office. That's great. But I'm still concerned about whoever gave her the Dilaudid. So, I might make a phone call. A lot of this at least tells you where they're in practice and things like that. And you can, of course, Google it and then maybe have a phone call. Why did you give this person 120 of these? Oh, they told me that they lost them and that you wouldn't do the prescription again. Not a good idea. It also tells me whether they're shopping pharmacies. If you fill a script on the same day from another prescriber, this system's not going to catch it. And I learned that by having somebody do that to me. So what's the future of it? Well, the sunset review basically is underway. This is an opportunity. They've had several stakeholder meetings. If you are part of the PDMP thing, you get a little text and a little email from Dora telling you they've got a stakeholders meeting, or right now they've got the Dora Sunset Comments Forum. And they do actually take a lot of our comments into this to make it better. I think the boards are very receptive to this, so it's probably worth you doing. If you need help, you can't figure out how to use it, you want to train your staff, they do have free training and everything up here at the PDMP at the dpocolorado.gov, and they'll help you sign up and all that kind of good stuff. And you just need an NPI number in order to sign up for this. So again, 33% is not greater than 55%. It's a good one to remember. Objective number 5, we are going to be able to identify alternatives. Oh, now we get to talk about alternatives. That is everything that you need to know for the state of Colorado. That is everything that they require on their site. And congratulations, because it's a little dry, but hopefully I made it a little fun for you guys. So let's talk about some alternatives. You know what the most important thing is? Not the alternative medication, but how you present it. Education, best practice, research, reframing pain. Some pain is good. What do we really need to treat? Use your screens. Is this a patient who is having a 9 out of 10 pain, but when you look at the oswestry, is really in that minor to mild category? There's something else going on there, probably psychological, pain seeking, whatever that might be. Set up a plan, use your agreements, do pill counts, do UAs. These things are huge, huge pieces that will have you be successful, will protect your license, but more importantly, will give your patients quality of life and protect their life. Use an expert. Please, I put up my personal cell phone at the beginning of this. Please contact our office or my personal cell phone if you have any questions. If I am not the expert at it, and I am definitely not the expert at everything, I will help you find one, okay? Because most importantly is what we're doing with our patients. The alternatives to opiates, of course, things like Tylenol, ibuprofen, naproxen, capsaicin products. They have a great product out right now called Cutenza, neuropathy of the feet. I just did my last, they comes in 3 things. I had a patient go through all 3. After the first one, he said, this is a lot better. I can tell when my foot is on the gas pedal and when it's on the brake. He'd been driving around like that for 3 years. I was really happy he could tell the difference now too. Next time he came in, he said, it lasted longer, and I finally understand why I need to wear shoes in the house. I have a lot of crap on my floor. His last one, he wasn't even sure he needed to take it for the first time in his life. And in 6 years, his feet was warm, and he could actually tell when he was in the shower and when he was on shag carpet, and he was feeling a lot better. So great product. If you're interested in it, we do it here. You can get it in your offices. SSRIs, of course, treatment of mental health. This is a big one. Treat PTSD. Take a look at depression. Do your GADs and your PHQ-9s. Find out if they have that. Refer out if you need to, but definitely do these things. Brain spotting. I love brain spotting. Let me tell you about this. This is an EMDR, and basically it's based off of the whole tapping and this kind of stuff. But all you have to do is go to YouTube. You can get the sound, you put your little earphones in, and you tell your patient for 3 minutes, I want you to listen to that music, and I want you to think about what it is that's causing you pain. What it does is it disconnects the emotional endorphin rush with the feeling and the logic of pain. And a lot of times I can get people down 3 or 4 different pain scores by having them do a brain spotting routine. I don't have to teach this. This isn't biofeedback. They don't have to know how to meditate. They just need to be able to listen to music on something electronic. Topical oils and compounds. I tell a lot of my patients, and this is kind of under the board, but a pearl of wisdom here, to go to the Hispanic bodega stores, because in that back bench where they sell their remedies, they compound cyclobenzaprine and diclofenac or cyclobenzaprine and gabapentin together. And you can get it in a cream. It costs you about $6 as opposed to the $150 if you write the script for it. Great thing. Compounds. If your patient is willing to spend $50 even for a month, a lot of times a compound cream will last 3 more months. You can add all sorts of things through it. I really enjoy working with Flatirons Pharmacy over in Longmont. They have a great compounding, and a lot of times can direct my compounding so that I know exactly what it is that I'm going towards. But you can compound in ketamine, you can compound in gabapentin, you can compound in all of these things, especially if I have patients that are a little goofy after they take this stuff, then this is definitely the way to go. Bupinephrine. I personally think if you are not a chronic pain prescriber and you want to practice and protect your license, Bupinephrine is your friend. Really, really low MMEs, really high response. 2 products. They have a patch that goes for 7 days, great for older people. They have Belbuca. You can microdose it. It's a little thing that dissolves in your mouth. Excellent way to go. If you have to go to an extended release, please go to something that's tamper-resistant formulations, things like Xtampza instead of OxyContin. I think you're really risking yourself by doing some of the ones that are not. And most of your insurances, especially after the large Purdue thing, are now paying for these. So please take a look at all of this type of stuff and really look at kind of going that way. Anti-Neuropathics, of course. The first 3, I got to be honest with you, I've never prescribed. Gabapentin, pregabalin, and Topamax. I love these. A lot of people won't do Topamax because it's a tricyclic, but I think that for neuropathy, these are 3 of the better ones that we can do. If you know the patient is going in for a surgery where you think that there could be some nerve damage of any sort, this is a great place to start, and I can help you with that. Alternatives, of course, your tricyclics, your SNRIs, your SSRIs, right? We all want that new drug. He really is. I want a new drug. I want it to be good, full head of hair, clear skin, multiple job offerings. Yeah, we don't have anything like that. But you really do have to explain to a patient why you're going to give them something like duloxetine or Prozac, because you're not treating, they're not depressed. You're not worried about that. You want more serotonin, less norepinephrine. That's what you're going for. Here's a list of my references tonight. I'm happy, of course, this will be on recording. This is, I think Dr. Romley's going to talk about how you claim the CME credits, but this is where you log on to and everything. I really want to thank you for joining me tonight. I've had a great time really presenting, and I hope that you have lots of questions and things that I can answer and help you out with. Thank you all for your attention.
All right, Jackie, thank you. That was awesome. We have 3 questions real quick before we go over how to get the CMEs. Number 1 is, Jackie, do you have any recommendations for patients that are being discharged from palliative care? Probably one of the best problems somebody could have is getting out of palliative care and going back, but they still need chronic pain management. What should providers do in that case?
So I think it's a great problem to have, but you're right, it's really difficult because oftentimes the palliative care, they don't necessarily have limits and stuff, and you inherit somebody who's on 300 to 600 CMMEs, right? I think one of the best things to do is have a discussion with that provider so that you can transition them back in. And one of the better things to switch to, you can take really high M&Es, and again, you can switch them to buprenorphine. There's a respiratory window in it. It works well for people that have breathing issues. It is not a really highly addictive type of thing. The other thing too is go over and make sure that you don't have an addiction going on. I love going to Suboxone on people and then going to Sublocade, which is an injectable. They don't even have to have, go to the pharmacy and deal with everything. But I think that probably the biggest thing is really having a discussion about, you're off of palliative care now, and this was used in a lot of ways to give you comfort and things like that. What else can we be doing? Because when you're not in palliative care, you were supposed to be kind of working forward, right, towards health again. And so, and tapering that 30% in a month every 2 weeks, that does not work on people that have had longer than a month of treatment. You need to taper slowly and involve your pharmacist in this. A lot of pharmacies are much better about filling and not making the patient feel like they're an addict. If you involve them, and I always give them a call and say, here's my plan, here's what I'm doing. Can you help me think of anything else that maybe I should be doing? But I find that by involving them in that, they might feel much more comfortable giving that up. If you need other things or you want to consult with this patient, even if it's a one-time consult and you want to run the treatment plan, give me a call. I'm happy to help you out.
Right, then the second question I saw that I had no idea how to answer was, is there, how likely is it in patients who are on linezolid that then receive tramadol to develop serotonin syndrome? And is that something you would hesitate to give?
So let's talk a little bit about serotonin syndrome. It's very real, but it's not as frequent probably as what a lot of the education recently has us believe. Tramadol is a factor, so is cyclobenzaprine, so is fentanyl. There isn't an opiate out there that doesn't have a warning about serotonin syndrome. And I think it's really, really important to, hopefully if they're on something that they are getting from another provider and stuff, have a talk with them about this. If I was really worried about serotonin syndrome, I would probably use the bupinephrine product first. After that, I would start really low dosing. Tramadol is my least favorite about this. I might even try a norepinephrine inhibitor like Nucenta. I know it carries a serotonin thing, but it's actually kind of a misnomer. If you understand how that drug works, it does not do a serotonin syndrome. So I would probably look at Nucenta as being a little bit better. Fentanyl being another bad one. You kind of have to pick and choose your way through this one, and it's a tough one. Jacob, you're still on mute.
Yeah, I got it. Jackie, do you get a lot of pushback on buprenorphine? And is it a different schedule that makes it difficult for PAs to give?
I'm assuming that you're probably saying from the patient. And again, it's about education, right? Because they go out to Dr. Google and Dr. Google says, oh, you give this to addicts. And I tell them, you know what? I'm not using it because you're an addict. I'm using much lower dosing. I give methadone to addicts too, but not at the dosing that they give to an addict. But it's a great neuropathic. It works wonderful in people with neuropathy. So first off, I do a lot of education and I say, you know what I really like about this, especially in men, it doesn't take down your testosterone, right? Leaves you with that little bit of So this is a great one to kind of go off on that one. I explain to them that it's lower. I don't get a lot of pushback. Medicaid loves bupinephrine. So Medicaid, you will always get your patches and things like that because the doc who does a lot of their approving is a huge bupinephrine fan. With everybody else, I try and tell them that, it's used in Europe for depression. My other meds, all my other opiates can give you depression. So I love it for that fact. It's all about the education about that. I don't get pushback from pharmacies. I always think it's kind of weird that it's like sometimes I have to fail fentanyl before I can give a Butrans patch. Yeah, you're right. That's really pretty stupid but it's expensive and that's what it's all about. And I usually fail the fentanyl patch because I deem that it is unnecessary for that high of an opiate dose. And I worry about the risk of overdose and sudden death with the fentanyl patch. And that's usually enough with the insurance companies that then they give me the approval on my Butrans patch or my Belbuca.
And last question we'll ask before we go over the CME information and move on to Dr. Leo. CBD oil. you see it everywhere. Everybody's rubbing it on everything. It fixes everybody's dogs and fixes every ail that people get. Is there a lot of literature on CBD? And I know that at least surgically, there's recently a couple of papers that come out and say that marijuana actually does not decrease the rate of narcotic utilization. What are your views on THC and CBD?
So I'm a big fan of CBD oil. I prefer that my patients get it from hemp. It has the lowest concentration of THC. You have to have some THC to get CBD into the cell. If you want a lot more education in CBD oil, the American Nurse Practitioners Association does a great certification in THC and CBD use. But I encourage my patients to use it. Not everybody's going to uptake it. We make a natural cannabinoid in the body. We have a natural receptor for it. And just like some people can't take Norco, other people can take Tramadol. It's the same sort of idea. THC. If you're as old as me, THC, the big THC back then was 12%. That was really smoking it up. 12% now is what they call floor pot. It's not worth anything but stepping on. So now they're doing these dabs that are 98%, okay? THC in that we don't even know yet what all the benefits are or all of the distractions. I do know that I see withdrawal with it. I do know that I worry about impairment with it. And I tell them this is my take on THC. I'm happy to transition you over to THC, but I hold a federal license and federally it's illegal. And I will not prescribe a controlled substance while you are on THC. The other thing that I know from being a nurse bedside is I could tell you the minute they came in to pack you if they were high marijuana users, because nothing I gave them calmed down the pain. And a lot of them, the first thing I would tell me when they got home was they smoked a little bit and all of a sudden they didn't need my pain meds. I think we're going to find out more. Your best research right now is still coming out of Israel. I do think that probably marijuana will get federal approval probably by the end of this year. But it's also illegal to drink on my meds. And, alcohol is legal. But if I catch it in your screen or if I find out you're drinking on them, you're not getting my C2s either. Again, protect your DEA first and foremost and wait for the information to come out.
All right. Thank you, Jackie. I'll let you keep answering questions in the chat room because as much as I try to help, I'm totally useless on this one. For anybody who's not going to be joining us for the second lecture, I'd like to tell you how to get your CMEs for this first hour. Go to the website www.yourcesource.org to obtain one CME lecture from Jackie for this. And I know that there were some questions after the last one because it's under SIPs and SIP and C is what it's listed under. We didn't choose that. Then the code that you're going to need to enter is 844202104, and an email will be sent later as well if you didn't get all that. But we'll move on to Dr. Leo's talk next. Dr. Paul Leo, also an impressive person that makes me feel bad about myself. He's a double board certified in anesthesia and pain management. He applies a multidisciplinary approach to pain management, which he combines therapy, medications, and interventional procedures to try to help patients obtain their life goals. He's performed thousands of procedures to include spinal cord stimulator implantation, intrathecal pain pumps, radio frequency and cryotherapy ablations, cervical and lumbar spinal injections for epidural and facet joints, trigger points, dry needling, and whatnot. Dr. Leo earned his medical degree at Sunny Downstate Medical Center in Brooklyn, New York, after 2 years of surgical training. He then completed an anesthesia residency at the Mount Sinai School of Medicine in Manhattan, where he also completed a pain management fellowship. He's practiced in multiple settings from a level 1 trauma center to community-based pain clinics. His specialties include interventional pain, regenerative medicine to include PRP and stem cell injections, medically assisted treatments, and anesthesiology. In addition to treating patients, he also enjoys training medical students who rotate through the practice. Little fun fact about Dr. Leo, he delivered his first baby on the same floor that he was born at Kings County Hospital in Brooklyn. which that shows you the people from New York typically never leave. So we'd like to thank Dr. Leo for joining us here in Colorado and being a great member of our practice. And Dr. Leo, why don't you go ahead and start?
Well, thank you, Doc, for the kind introduction there. And I just want to say to everyone, thanks for being with us tonight. If you are staying on for this part of the program, realize you just got a real treat, because you had the nuts and bolts of what's been a changing field in pain management and opiate use put into a digestible form in an hour, and that's really hard to do. So that was really well done, and it's going to be a very hard act to follow. So we'll give it a go here. So what we want to look at now, since you've had a discussion about opiates and some of the non-opiate medications that are good alternatives for this, is what are some procedural things we can do? What are some of the adjunct treatments that will be helpful as we move forward and try to find ways to use methods of decreasing patients' pain without medications or without opiates, so that what they can have will work better for them. And there we go. So what we're going to try to do here is look at treating pain through an integrated and multidisciplinary approach, what that means, a multimodal approach, so that it's gone from, okay, we're going to provide you with a medicine and that's all there is to it, and realize that there are multiple medications, multiple treatments, and multiple clinical approaches that can all work together to make this easier to do. We want to take a look at what's available to patients, and things that 20 or 30 years ago would not have been considered are now things that are covered under insurance, and just how we wrap that all together. So as Jackie already went over, for some of the more recent groups that are involved in helping to set up the guidelines, Center for Disease Control, American Pain Society, American College of Physicians, osteopathic medicine, and interestingly enough, apparently the veterinarians have joined in. So I found that to be a good addition to what's happening for us these days. So what are we really talking about when we're talking about interdisciplinary team? And this used to be the really the old model, the original model of a pain program was sort of everything under one roof, where you have pain physicians, surgeons, psychologists, therapists, and PM&R docs and PT and everything, and they kind of can walk around and be sent to the appropriate department, their daily meetings, weekly meetings, and trying to all work on the same plan and moving people in the same direction. I think that went out of favor because it was getting harder and harder to pay for. Many years ago, it's actually coming back into favor. And really what we were left with was a more multidisciplinary approach, which means that we are getting different people to help treat, but they're not in the same kind of contact. And what I've seen, I think one of the positive effects that we're going to get out of the COVID crisis and the use of telemedicine is now you can take a multidisciplinary group of doctors who are treating a patient, and if you have to, you can get everyone together on a Zoom and talk about it. And so we start getting more back to an interdisciplinary model. About 10 years ago, I had a patient who was near suicidal, and we had to gather his psychiatrist, his psychologist, his primary care, myself, and his surgeon all on a group phone call. And that took some doing at that point, and the technology is much better. And I think that puts us in a much better position to be able to offer this to patients and improve their care. One of the advantages here at Center for Spine and Orthopedics is, since a lot of us are under one roof, there are times when I can just walk down the hall and talk to Jackie or talk to Dr. Rumley or one of the other surgeons and say, hey, you sent me this guy. here's what I think, what do you want me to do, or how do we want to do this? And so it's much better when you can have an open communication between the providers. So this slide is interesting to me because when we talk about treatment modalities, and what I have here is alternative care really is no longer alternative, because most of these things have become much more accepted over the last 20 to 30 years. In the old days, if you will, if you talked about sending someone to an acupuncturist, it was like sending them to a witch doctor, and an acupuncturist would tell you that an allopath was going to kill them. But now this has become recognized and is being more recognized as something that we can bring together to work together, so that when we think about pain management for the chronic pain patient, or even for the acute pain patient post-operatively or post-injury, we start looking at integrating physical therapy as soon as possible, integrating massage therapy, perhaps therapeutic touch, acupuncture, Ayurvedic medicine, other traditional treatments are much more accepted, and for different patients and different demographics or with different backgrounds, that may actually be more helpful and supportive. Chiropractic and osteopathic medicine, treating alignment, getting the body back into the proper place so that it will function more effectively and have less pain. Something as simple as someone who's had an ankle fracture and they've been in a walking boot for 3 months can completely change their spinal alignment. They start having hip pain and knee pain on the opposite side. Their back starts to get bad, and that needs to be put back into place after they take the boot off to get them back to moving. Body movement techniques, Tai Chi, yoga, Qigong, Pilates. There are studies now that show that these things actually help build body mass and help build bone mass, especially for older and disabled patients. As we went into quite deeply in the first section of this, psychiatry and psychology, basically chronic pain and depression go hand in hand. And if you are not treating somebody's depression or the effects that this is having on them, and incidentally on their family or their caregivers, you have a much lower chance of having a successful outcome. And I will many times have patients get very angry at me or very upset with me for sending them to a psychologist or a psychiatrist because I think they're crazy. And I do have to spend time educating them to help them realize that I understand that they're depressed, and that that's a big part of what's happening. Someone's lost their job, they've lost their self-esteem, they can't provide for their family. All these things have to be addressed before we have a better chance of a good outcome. So under that umbrella comes things like biofeedback, cognitive behavioral therapy, hypnosis, guided imagery. Jackie was talking about brain spotting and some other things, and really a recognition of things like PTSD, and that there are treatments like EMDR, and that if you're a patient who had a car accident and comes to you 6 months later, they're still in pain, and oh, by the way, they walked because they just can't get in the car anymore. Those things have to be addressed, because if they are not addressed and brought to light and help, they will find a way to burrow their way up to the surface, and they will complicate things as you go forward. So now we start going into what's available. I labeled this slide as a non-mu receptor agonist, and then I added in a bunch of mu receptor agonists because I'm going to look at their use only in the CSF for intrathecal pumps. Among the novel agents available, one that has risen to the top of medications that can be used in an intrathecal pump is Prialt, or Ziconotide, which is actually one of the molecules that is in the neurotoxin of a small cone snail that lives on the reef in the South Pacific. And this, among other components, have been taken out and can be given intrathecally. It is a non-opiate receptor drug. It works at an N-type calcium channel blocker, and it can't be given orally because it's such a large molecule. It's a protein, it would get digested before you could give it anyway that way. So tiny, tiny doses of this, it's about 1,000 times as potent as morphine, tiny doses of this can give unbelievably good pain relief for patients and allow them to get off of their opiates and some of their other medications and start to move and return to a more normal existence. Other medications that are approved for intrathecal use include morphine and Dilaudid, fentanyl, clonidine, and baclofen. And baclofen is an antispasmodic and is actually used more often for patients who are post-stroke and have spasticity from a stroke, or are post-spinal cord injury and have spasticity from that. So patients who are on such high doses orally that they have significant side effects can now be taken care of with small doses and therefore much less side effect. Since we have had the opioid crisis and we are now reticent to give opiates for just about anything, ketamine has become quite popular in a lot of settings, such as emergency rooms and for a variety of acute and chronic pain treatments. The interesting thing is, while I was an anesthesia resident, I was taught how to use ketamine by one of our attendings whose brother was a doctor in Africa, and he'd go give him a break for a month and then come back and teach us all about ketamine because that was basically all that they had. And it was very useful because it's a very strong analgesic. It's also a dissociative drug, so it's almost a hypnotic. So the patient will be unaware of what's happening, but it also has a large psychoactive component. And patients will wake up and be very upset because they've had bad dreams, or what they describe as bad dreams. And that can usually be ameliorated with a small dose of Versed, because then they don't remember they had the bad dream. So that's a part of the mixed anesthetic. In the non-OR setting, this is now available as an intranasal spray for patients with headaches and some other pain conditions. It's available intramuscularly, and there are now, quote, ketamine clinics, which are being used for IV dosing under monitored care. And it's treating not just acute or chronic pain, but there are applications for depression and associated problems like PTSD. Steroids are used fairly freely for joint injections. We use that for epidural injections and nerve root injections. And those are helpful as powerful anti-inflammatories, but I think that we are showing, now that we have some good alternatives, that long-term use for many repeated injections will actually start to degrade the patient's situation from the side effects. And the fact that we can give small doses, for instance, into the epidural space, as opposed to large doses and Medrol packs by mouth, does mean that the side effects stay down. But certainly for a number of patients, such as diabetics, this is something that we have to watch. So injections, and this is the fun part of the day for me. This is where I go get to be on the dull end of the needle and have a good time every day. So we have injections that can go to multiple sites. And we'll just start in the middle and work our way out. Intrathecal injections are typically these days used as part of trialing for an intrathecal drug system, which we'll talk about in a couple of minutes. You can use intrathecal alcohol or phenol for patients who have end-stage cancer for ablating nerves that are causing intractable pain. They will also lose motor function with that, but these are usually people who have days or weeks to live. We can do injections in the epidural space. We can do injections around nerve roots, and these can be targeted very closely with X-ray, C-arm, or with ultrasound now. We can do intradiscal injections, and those are typically diagnostic at this point, but they can also be injecting steroids, or some of the regenerative techniques that we have are being injected. There's a lot of research still to do there. A major pain generator for people who have axial pain, so their neck pain radiating to the shoulders, or their back pain radiating down into the backs of their legs, their buttocks. These typically are referral from facets. So when people start having arthritic facets, we can inject those. if we get great relief, but it doesn't last long, then we can start doing radiofrequency ablation, which is burning nerves that are sensory only, in this case to facet joints, or now there are some good blocks we can do for knees and hips as well, where we ablate the nerve. It takes about a year to grow back. So essentially those small areas that can be very specifically targeted are unable to provide a pain signal. So the patient's much more comfortable. They can decrease their medications. They can increase their exercise and their physical therapy. And sometimes they don't need to repeat them. I do have patients who we've been doing this for many years, and they come back about once every year and a half or so to do that because the pain comes back. Something that really was not available when I was a resident, a fellow, are peripheral nerve blocks that are ultrasound guided, because that technology didn't exist. And if you were doing those, you did them on the basis of anatomy. And nerve stimulators, which have gone almost completely out of use, so that we can now target specific nerves in the arms, the legs, or the trunk, and inject those and potentially stimulate those now, and give long-term pain relief in that fashion. Also sympathetic nerve blocks. These are typically for some of the neuropathic pains or sympathetically mediated pains. What is now CRPS types 1 and 2, which used to be RSD. And so we can block the sphenopalatine ganglion, which sits right at the back of the nose, with either needles or a Q-tip. We can do stellate blocks here, which is for the face and head and upper arm. We can do the thoracic chain. Have to be a little careful there and avoid the pleura. Lumbar sympathetic blocks for leg pain, and the ganglion impart for more of a perineal kind of pain. Agents available: local anesthetics, steroids. There are neurolytics that can be chemical, typically alcohol and phenol. We can heat, coagulate, and freeze nerves. Regenerative medicine is coming into the forefront, still not FDA approved or covered by most insurances, but this includes prolotherapy, which has been around since the 1930s and is essentially causing an inflammatory response by injecting sugar water, which then causes a healing reaction, if you will. Platelet-rich plasma, where we take the blood, spin it down, take out the platelets and the proteins that would show up for a healing response, and put them exactly where we want them. Mesenchymal, quote, stem cells, unquote, which are pericytes, and those are recruited when someone has an injury. And so we can get stem cells from bone marrow harvest and spinning that down in the office. It can be harvested from fat. The FDA has some issues with that technique right now, and it takes about 4 or 5 hours to do, and the patient has to stay in the office the whole time. A good source of cells now is through Wharton's jelly from umbilical cords, which when properly harvested can be frozen and transported and injected that way. So implantable devices, this is sort of more of an end stage after we've tried medications and have unacceptable side effects, or we're unable to control the pain any other way. We have spinal cord stimulation. And what you'll see down there is 2 devices and their current battery packs next to a porter. We have an intrafecal pump so that we can deliver medications that we discussed a little while ago directly into the cerebrospinal fluid and directly at the receptors in the spinal cord. So-called targeted drug delivery, because it turns out that where you put the tip of the catheter does matter. So higher up or lower down, depending on where the entry zone for the particular nerves are. Peripheral nerve stimulation has become much more accessible because of newer technologies. And really the biggest problem here then is matching the right patient to the right device, if we've come to that point. So spinal cord stimulation has been around since about the mid-1980s. And something really to think about, having looked at that picture a moment ago of one of these batteries that can be implanted sitting next to a quarter, is that the first things available were a single electrode and a battery about the size of a pack of cigarettes or a deck of cards. And today we have the internal rechargeable batteries that you see there. They communicate to a programmer that allows multiple ways of using the device, basically through a Bluetooth type technology. And one company now has up to 64 independent electrodes that you can implant with 4 leads. And so you can stimulate almost a third of the spinal cord and cover that. Traditionally, this was started for quote, failed back syndrome or post-laminectomy syndrome for leg pain, and more recently back pain, as we've started using different frequencies and different waveforms that allow us to reach those nerves. It is also very good for neuropathic type pains, pains from nerve injuries, phantom limb pain, that kind of thing. Chronic regional pain syndrome type 1 and 2, those used to be RSD and causalgia. It is useful for treatment of end-stage ischemia. So you can put this on and it effectively gives you a sympathetic block and can reperfuse a limb that would otherwise be unsalvageable. It is also used for end-stage angina pectoralis in this country with a little bit of tweaking and widely used in Europe for that. The mechanisms of action have continued to change as we have learned more about what's going on as technology has improved and we've used different algorithms. Initially, this was affecting the dorsal columns, which was interrupting the signal from the body up to the brain. Functional MRI began showing that this actually affects the brain in many places as it follows the pain pathway around. Once we started using high frequency that the patients can't feel, it became evident that it wasn't stimulating the dorsal columns. There is stimulation directly of the dorsal root with a specific, very small electrode that you can place there. And it looks like high frequency stimulation above 1,000 hertz, which is imperceptible to the body, is actually stimulating glial cells and astrocytes, which then are secreting interleukins and other things which directly affect the way the neurons work. And that's where it's happening. So it's probable that when we're using these things, that one or more things is working at the same time. And these are done with a trial. Once everything's done, you place leads, they're externalized. I had a patient come back after a week and said, "This is amazing because I've gained 2 pounds." And she's a tiny little lady who would blow away in a high wind. And I said, "Well, what do you mean?" And she said, "This is the first time in 10 years I haven't had pain and I feel like eating." So that was a positive trial. I implanted that one about 6 or 7 years ago, and she still has that functioning for her. Intrathecal pumps. So this is where we have high dose of medications that are causing so many side effects that we want to try to put them directly in the CSF. Again, a trial is an intrathecal dose, single shot spinal now. And then that gives us an idea of whether or not this works. We watch the patients for 4 hours and then we can send them home. This is much more refined than a few years ago. Things we're looking at are for chronic pain syndromes, things nothing else helps. Failed back surgery that a spinal cord stimulator doesn't help. Cancer pain. I've taken patients going in and adjusting their dose every 2 days as they became closer and closer to death to try to help their pain. Complex regional pain syndrome responds very well to this. Chronic pancreatitis and postoperative abdominal pains. Peripheral neuropathies, arachnoiditis. My current absolute poster child for this is a gentleman who had a thoracic outlet syndrome repair gone wrong when they had to close up because he was bleeding to death. They came back and fixed it, and then it broke down, and he ended up having a trapezius flap to cover it. And basically for 20 years could not be touched from the angle of his jaw to his mid-thoracic region, including his right arm, and was on high doses of opiates and stated if it wasn't for his children, he'd have killed himself long ago. And we did an injection for him at the surgery center, and 2 hours later, I walked around the corner and he was holding his phone in his left hand and using his right hand to type the screen. And the first time I ever touched his right arm, I thought he was going to slug me. we went ahead and put a pump in him, and on the lowest dose possible, he began decreasing his opiates at home on his own. He's now on 4.5 micrograms of this highly potent medication a day. He's tapered off of his opiates. He was recently able to drive across the country and take his daughter to school in New York and then fly back on his own. The interesting statement that came out of that is that his daughter, who had never seen him when he wasn't in pain, looked at him one night in one of the hotels and said, "You know, you're not so bad when you're not a grumpy son of a bitch." So that was, that's really just been an amazing result. And these things obviously can't help everyone, but they certainly can help. Peripheral stimulation has opened up a whole new thing. We can do injections almost anywhere in the body now and be confident of where we are and that we're not damaging a nerve with ultrasound. Originally, peripheral stim was available only to neurosurgeons because they took epidural leads from a spinal cord stimulator and sewed them right on the nerve, and that was not available to practitioners such as myself. Now we have redesigned those leads. They can be placed percutaneously. You don't put a battery in. They have a little battery pack about the size of maybe a small pack of gum that attaches to the skin, and that's what runs it. And they have an external device that can work on that. So if you have someone who gets good relief from a peripheral block, say a tibial tunnel, a tarsal tunnel, a lot for arm and shoulder pain for carpal tunnel patients who failed surgery, you can do a block, they get relief. You can do a trial of stimulation where we place the lead, turn it on for a half an hour, and they get pain relief, and then come back and percutaneously place this little lead and change their status completely and how they go. So really, here's the problem when we're going to go with devices is, are we improving their quality of life? What's going to work? This is a surgery. This is an implanted device. It is not a benign process. It's certainly one of the less dangerous things we can do, but all of these things are fraught with danger when you put in an implanted device. But for patients where nothing else has worked, if you select the patient properly, they need a psychological exam. They need to be checked to make sure that their depression is under control. You do a trial that works and you put one of these in, it's an incredibly rewarding experience for me and the patient. My guy with his arm and shoulder, I tell him, I say, you know, I know I'm the second happiest guy in the room right now because this is working so well for you. And we move on to surgery. That's for Dr. Rumley and Dr. Jansen and Dr. Schnell and Noel here and our podiatrist, Dr. Kuhlman. So there are things where we have to go in and fix the anatomy because there are things that stimulators and meds won't help if you're directly compressing a nerve, if you have parts that move and shouldn't, and that sort of thing. So spine, decompression, disc replacements, fusions, there's been so much advancement in disc replacement technology where you maintain people's motion. Orthopedists with joint replacements and with abilities to now do plasties and resurface and reline some of these joints and get that for people, or just repairs in general of broken bones, general and gynecologic surgery for the pancreatitis, for pelvic pain, things like that also need to be part of the equation and sometimes need to be treated afterwards. The effects of chronic pain are on the patient, they're on the family. We can now demonstrate that this remodels the central nervous system. So if you're in pain for a long time, it changes your brain and it changes how you feel pain and how you see the world, and the depression that we talked about before. You can show that the brain degenerates in certain areas and gets bigger in others. So I went with this only because I have told patients before when they wonder how I can push on them and say, wow, that really hurts, that the no pain clinic is down the hall. So finally pulling this together, you have to do a good consultation. You have to take a good history, and this takes a long time because sometimes patients have seen 10 or 15 other doctors, and I've got to try to figure out where is this coming from and what can we do or what have we missed. It's a good physical exam. It's going over the labs. It's talking with the surgeons who send them and the people who are going to work with you. You try to put that together, you try to make a rational plan, you try to educate the patient on what's going to work. You use the tools that we've discussed that are at your command. Dr. Google is not always our friend. And I will send patients to look on the internet, but it's like if I'm going to do a Medtronic implant or a Nevro implant, I used to have a CD that I would hand them that would be, here's what this is about. So now they need to go to the website and look that up. And what they have to do is avoid the stuff that's really not educational and that's just going to mislead them. So we just put about a year's worth of work into about 20 or 30 minutes here, and I probably missed out and left out a lot of stuff. So if there's questions, I'll be happy to try to answer that. Certainly, you can reach me here anytime, and we can talk about things and try to help out with that, and be happy to try to make your patient's life better, and by doing that, make your life better as well.
All right, Dr. Leo, thank you. That was awesome. I got to say, from my personal experience, I believe that I did that case with you where we did the pre-alt for the guy who had the complex regional pain syndrome, and it was so bad that we actually had to change how we positioned him on the OR table because his arm was so affected. We couldn't put it above his head really. And yeah, after surgery, you brought me over into the room to come check him out. The guy like lifted his hand to shake my hand. It was one of the more powerful moments I've had. You know, as a surgeon, we always kind of think, how do we fix this surgically? And when we meet people with CRPS, I always wonder how they haven't committed suicide. Their pain is just unbelievable, and I know that there is a high suicide rate with those patients. So
it's kind of cool to see the corners of his mouth go up for the first time.
Yeah, I mean that guy was that was amazing, and I've actually become a huge believer in that. One thing, on the topic of chronic regional pain syndromes, it's certainly one of the most devastating things that I've ever seen, that arachnoiditis. And early intervention is key, and getting it to people who know how to manage this, like Dr. Leo, to get things like stellate ganglion blocks, to get them on vitamin C and those things can actually surprisingly save their life. So thanks for bringing that up, Dr. Leo. That was wonderful. And once again, you're an impressive human being, and I'm proud to be your partner.
Thank you very much. It's very kind of you.
So we've had a lot of questions in the chat. Most of them are that I saw and I commented on were about muscle relaxants. And Jackie, are you available? Just because Jackie gave a wonderful synopsis of what muscle relaxants to give when, because as a lowly spine guy, I tend to be afraid to give anybody anything that's overly sedating, especially post-operatively. So, because post-operatively they get narcotics. So I usually avoid Flexerol. I give some tizanidine. The question was, what about giving Valium? I'll sometimes give that for 24 hours after surgery.
Jackie's offline right now.
Yeah, I see that. So I'll give a benzodiazepine like Valium for maybe 24 hours after surgery, but I even really avoid that. I can count that on a single hand how many times I've given it. So my go-to is Robaxin. I feel like I get excellent modification of their pain. I don't really use it as a true muscle relaxant because, as we all know, a lot of these don't work at the motor end plates to get true muscle relaxation. People stop breathing. So other options, I know Dr. Leo and Jackie have really turned me on to tizanidine because you get some benzo-like effects from it, especially at the time of sleep. And Jackie made a good point that when you're prescribing a muscle relaxant, sometimes giving them two different kinds of muscle relaxants can be a good thing because each of them has their benefits. So I'm a huge methocarbamol fan because I don't like that patients have reported to me that they feel high when they get Flexerol. But getting something at nighttime to help sleep, like a tizanidine, so they take their methocarbamol during the day, tizanidine at night, or Flexerol at night, is a great idea. And that's something I've actually started to adopt. And I'll ask my patients now, when is your muscle spasm the worst? And if it's middle of the day, I give them methocarbamol. If it's at nighttime when they're trying to go to bed, then I send them to Jackie to give to Xanadine. But yeah, I think that's a great way of looking at it, because if we just try to be too straightforward and give everybody the same thing every time, that's not treating the patient, that's treating an algorithm. I don't think that's the best way to do it. So I'd like to thank everybody for coming tonight. Thank you, Dr. Leo and Jackie, for your lectures. They were wonderful. The topics that certainly I should probably know more about, and I love listening to you guys talk about them. If you guys would like to, if the listeners would like to learn about some of our patients, we have some good patient stories on our website at centerforspineandortho.com, where you can read their stories and see some patient videos. I'd like to also invite everybody on June 9th. I'm going to step down from the moderator position and take on the presenter position. And I'll be presenting on tandem stenosis. It's a problem that's hiding in plain sight. So I'll be talking about patients with lumbar spinal stenosis that also have cervical spinal stenosis and what the treatment algorithm should be for that. In terms of claiming your CME tonight, go to yourcesource.org. Go to claim CE credit, then under there, enter the code for 844-202-104. If you didn't get that, don't worry. I put it earlier in the chat, and Karen Johnson will be sending that in an email tomorrow. When you're in there, if you watched both hours, which are on here, hopefully you did, you can claim 2 CE credits for that. And if you submit these by April 30th, that will meet the state deadline for our opioid training, which is required for our Colorado medical license renewal. The other thing I'd like to do is thank our sponsors with Health Images, Annette Reeder and Adele Gamel. I hope I'm saying your name right. Without them, this would truly be an impossible event. So with that, Jacque Carbone, Dr. Leo, I'd like to thank you guys both for coming. It was awesome. I learned a lot. And once again, thank you for being such wonderful partners.